Hi, I'm First Lieutenant Emma Shirey, and today I'm going to be teaching you about the nursing management of implanted vascular access devices. Today's learning goal is to increase the knowledge base of nurses assigned to CRDAMC about providing safe nursing care for patients with implanted vascular access devices. The objectives for today are to identify the location of implanted vascular access devices, to describe the purpose for implanted vascular access devices, to distinguish between the benefits and the risks of implanted vascular access devices, and to demonstrate how to access, draw blood, and deaccess implanted vascular access devices. There are three locations where you may find a vascular access device. They may be placed intravenously, intraarterially, or intraperitoneally. Purpose for implanted vascular access devices. The device is placed completely under the skin surgically by an interventional radiologist. It is used for patients who require frequent or continuous chemotherapy administration because chemotherapy drugs are very toxic and irritating to the skin, tissues, and veins. Chemotherapy medications are administered into a large central vein or artery so that they can be immediately diluted by a large volume of blood and be delivered effectively throughout the entire body. Implanted vascular access devices, also known as portacast or a passport. Their implanted chamber is placed in the sub-Q, usually on the chest wall, but maybe in other areas. A catheter attached to the chamber terminates in the central vasculature. Ports that are placed over the lower ribcage or abdomen may be for intraperitoneal use, but must be verified prior to use. They can be placed in a low, moderate, or high profile, and there are single lumen, double lumen, passport, or power port. Here we have a cross-section of an implanted port. You can see that the port is placed directly under the skin, and the catheter is placed into the vasculature. Some benefits of having a vascular access device. It's used for long-term access. It can be used for years. It requires minimal maintenance, flushing every month or 4 to 6 weeks. It's a central line for blood draws and medication administration. It gives the patient freedom of activities. It has the lowest incidence of catheter-related bloodborne infections. It has less effect on the body image because it is placed directly under the skin, and there's no dressing required if it's not accessed. Some risks or complications of vascular access devices. These devices can infiltrate from needle dislodgement or improper insertion, occlusion if not accessed or flushed properly, skin breakdown, infection, thrombus formation, or catheter fracture or migration. Another complication of these vascular access devices is the pinch-off syndrome. Pinch-off syndrome is where the catheter gets compressed or pinched between the first rib and the clavicle, causing an occlusion for both infusion and withdrawal. So you can see in this square that that is where the pinch-off area is. Know what you are accessing. Most single lumen implanted vascular access devices are power ports, but many of the power ports feel like the smaller double lumen when palpated. Always verify the type of port prior to use. Most times you can just ask the patient and they will know what kind of port they have. So here's some pictures of the single lumen and double lumen vascular access devices. And you can see that they're not very big compared to that quarter. Another complication of ports is when they actually flip and then you cannot access them. You can tell by an x-ray, you'll see the C and the T on the back side of the port, and that means it's flipped and it's not accessible. Accessing ports. Prior to initial use, make sure you verify the provider order and line placement, access site and ipsilateral chest, notify the physician, and do not access the port if any of these are present. Redness, tenderness, warmth, or swelling. These could be signs of infection. To access, make sure you're using a non-coring Huber needle, the shortest needle possible, and sterile pre-filled syringes. After accessing, make sure that you document the gauge and the length of needle used. Currently, we are working with vendors to develop a one-grab port accessing kit that includes everything that is needed to access ports. At this point, we don't have those. We have to grab from the supply room different supplies, but hopefully in the near future, we'll have a one-grab kit so we can access these quickly and effectively. Here's a couple pictures of different types of Huber needles. And here's some pictures of what ports actually look like. Good ones and bad ones. Port flushing. When flushing a port, you should use 10 to 20 milliliters of saline per lumen, and then you should flush with 5 mLs of 100 units per milliliter or 500 units of heparin. A maintenance flush should be done every 4 to 6 weeks when the port is not accessed. Monthly is recommended, but it can go up to 6 weeks. Maintenance for a port that is accessed, the needle, the cap, and the dressing should be changed every 7 days. If it's soiled or damp, it can be changed sooner than that. When drawing blood, you should discard at least 5 mLs of the initial blood draw. You should then draw the desired amount of blood and then flush with 10 to 20 milliliters of normal saline per lumen that was used. And then if you're deaccessing the port, you should flush with 5 mLs of 100 units per milliliter of heparin. When deaccessing a port, once again, you want to flush with 10 to 20 milliliters of normal saline per lumen. You want to flush with 5 mLs of that 100 units per ml of heparin, so 500 units of heparin. You want to maintain positive pressure when flushing, remove the dressing and inspect the site, stabilize the port, have the patient hold their breath while withdrawing the needle, then apply pressure and then apply a dressing. In summary, so today we identified the location of implanted vascular access devices. We described how the implanted vascular access device functions. We distinguished between the benefits and risks of implanted vascular access devices, and we demonstrated how to access, draw blood, and deaccess implanted vascular access devices. Are there any questions?